session starting now. Um, so by participating, you consent to be included in the recording. If you've got questions, go ahead and email us. Make sure you mute your microphone. You're encouraged to have your video on, especially when we get to the case presentation and discussion. We find that super helpful. If you have any issues, there's the phone number or email there. And then just make sure that your name is up to date as well. Instructions there is just click on the three little dots above your face, and then you can rename that to be your name. It's helpful to see your presentation or your organization also. Raise your hand if you want to speak when we get to the case presentations. You can also submit questions in the chat as well. We'll answer as many as we can during the session. And then just a reminder about private health information. So making sure that you're not bringing in, patient names, location, dates, etc. And welcome. Thanks everybody for joining. We're excited about today. Some notes just about the program in general. Our tenets are obesity is a chronic and relapsing disease. We want to make sure to encourage using person-first language and just establish that this is a safe place to learn, share your experiences, and ask questions. So it's meant to be a very dynamic, especially when we're talking about case presentations and that. Here's our quick agenda of the session. So doing our introductions now, we'll have a presentation and then the case study and go over questions after both. So today's topic is diabetes and obesity, and we have Dr. Patel joining us today. So thank you, Dr. Patel, and we'll hand it over to you to kick your presentation off.
Okay. Can you guys hear me?
Mm-hmm. Yeah.
Okay, my name is Rutha Patel. I'm an internist by training. And over the last 3 years, I've been working in an obesity medical surgical specialty practice. And as you know, we take care of a lot of patients with diabetes and obesity. And how should we be approaching these patients? And is there really a big difference in the way we manage these two disease states? So I want to kind of create a bit of a scenario where I want to get an idea that instead of focusing on managing people's blood glucose, that if we change the way we think about this problem and start thinking about how to manage their insulin needs and insulin production, that we get better outcomes. So why an insulin-centric model approach outperforms the glucose-centric model when it comes to both treatment of diabetes and obesity? I speak for Lily, so I just wanted to put that in my disclosure. Okay, so what are our learning objectives? Understand that the pathophysiology and progression of insulin resistance and diabetes. Understand how medication management can be applied to both obesity and diabetes simultaneously. And understand how proper understanding of disease state can lead to better cardiovascular and renal outcomes. Oh, sorry, I clicked too much. Okay, so the problem. We've been treating the symptom and not the cause. So glucose elevations are a consequence of metabolic dysfunction. Traditional diabetes care focuses on lowering A1C, lowering blood glucose, rather than addressing the hyperinsulinemia, which honestly, most of us don't even test for. But high insulin precedes high glucose, and yet we end up waiting for the glucose to go up before we start treatment. And the result is short-term glucose control, which continuously requires dose escalation of medications, which leads to progressive weight gain and worse cardiovascular outcomes. So what is hyperinsulinemia? And why does it matter for the management of diabetes? So normal insulin function is that, okay, circulating glucose goes up postprandially, insulin is secreted by the pancreas, glucose uptake to the muscle, glucose uptake to adipose tissue, and decreased glucose output from the liver. That is the normal function of insulin. As we become more and more insulin resistant, this dysfunction leads to reduction in muscle uptake of glucose, increased de novo lipogenesis, so the blood sugar turns into fat and increases the triglyceride uptake into the adipose tissue, and actually doesn't tend to tamp down the the glucose output from the liver. So we end up having increased prandial output of glucose as well. So now, why do I make the case that we should be focusing on insulin instead of glucose? Because if you look at this graph, that was actually helped design the HOMA-IR test, showed that if we look at insulin, we see that insulin increase starts going up years before we have reduction in beta cell function and then the development of type 2 diabetes. So if we are trying to treat obesity, we really need to be thinking, how early can we intervene, maybe so that our patients never actually develop diabetes? So what should we be looking for? If you look at over here, so 12 years downstream from a diagnosis of diabetes, we have 100% beta cell function, and we're overcoming hyperglycemia by increasing insulin production. As time goes on, we get impaired glucose tolerance, then we get postprandial hyperglycemia, then we get a reduction in insulin production capacity by about 50%. So now we've already reduced beta cell capacity in half. That's when the blood glucose starts going up because our body's mechanisms cannot overcome that issue anymore. And then the traditional medicine advice begins, where we talk about diet, exercise, medication, and weight loss. But what if our interventions began here and we really had a more obesity, insulin-centric way of thinking about diabetes instead of a glucose-centric way of thinking about diabetes? So what does this mean for when our patients are already here? How do we think differently? So insulin resistance is when the cells in our muscles, fat, and liver don't respond well to insulin and cannot easily take up the glucose. As a result, your pancreas continues to make more and more insulin. And as long as your pancreas can make enough insulin, our glucose remains normal. But it is doing that at the sacrifice of body fat increase. So in the standard glucose-centric model, we've been measuring and managing A1C as a primary endpoint, prioritizing glucose lowering at all costs, like adding insulin, adding insulin secretagogues like glimepiride, glipizide. And the result has been weight gain, increased resistance, and ongoing risk of cardiovascular disease. So the reason this hyperinsulinemia matters is because the patients experience symptoms from the elevated insulin, and those symptoms are fat accumulation and increased perception of hunger in the presence of excess calories available, and continued worsening resistance. So glucose elevation is the effect of the metabolic dysfunction and not the primary cause. So what do we do, right? In the DIRECT trial, this was done in the UK, they showed that if patients were put on low-calorie diets and they lost weight, 46% of them achieved remission via weight loss alone. Problem was that for a lot of them, it wasn't a sustained remission because weight recurs. Obesity is a chronic disease, and we do see recurrence of weight. So while we know that weight loss can improve diabetes outcomes, the sustainability of that lost weight is what we want to look at. In the look ahead trial, we found that weight loss improved both glycemic control as well as reduced medications. GLP-1s and SGLT2s lower glucose by lowering insulin, and in the case of GLP-1s, promoting weight loss. So if we think about when we are looking at a patient, what is going to impact their obesity, we are actually going to also improve glycemic control. So what is the proof of concept for GLP-1s and GIPs? Lower glucose by reducing insulin exposure and promoting weight loss, improve insulin resistance, hepatic glucose production and appetite, and give beta cells a rest. What we know from GLP-1s is that GLP-1s actually increase production of insulin, but they do it in a glucose-dependent way. So your body is not exposed to high levels of insulin when glucose is normalized. So the more we normalize that glucose and we reduce those big spikes in blood sugar and then also reduce perceived hunger, patients can have sustainable changes to their weight and glucose. And we all know that GLP-1s actually improve cardiovascular outcomes, which was actually not true with intensive insulin and glimepiride control and sulfonylurea control, where from the Accord trial, we learned that if we intensified glucose modulation with increasing insulin, we actually worsened mortality. So when you compare outcomes of a glucose-centric model versus an insulin-centric model, we see a reduction in A1C that is short-term. Most glycemic control improves with sulfonylureas for about a year and a half, and then eventually we are worsening beta cell function because the sulfonylureas are actually increasing endogenous insulin production. Eventually, we worsen beta cell function and they stop working, so we start seeing an increase in insulin again. Weight increases, insulin resistance worsens, and the medication burden tends to increase over time, and remission is very rare. So this is a case study of a 53-year-old woman who was referred to our clinic. She had a BMI of 35 when we saw her. She was referred by her primary care physician because she had been struggling with weight gain for many, many years. So she had already lost from her high weight 40 pounds through diet and exercise, but she also had type 2 diabetes, at which point her primary care doctor ordered tirzepatide. She lost an additional 30 pounds with the addition of tirzepatide, but her symptoms didn't seem to get better. So she said she had minimal meal intake. She doesn't really eat breakfast, 3 to 4 meals a day. And sometimes she would experience uncontrolled episodes of eating, which she didn't really say was like binge eating, but it was usually happening on days when she wasn't eating much during the day. Her primary care doctor added phentermine, which initially helped curb her appetite, but she felt it was less effective and she did not actually lead to much weight loss. She was currently on tirzepatide 10 milligrams and insulin 75-25 with doses of 22 units, 26 units, and 20 units. So on average, when we look at the human production of insulin in patients who are insulin sensitive, they are using anywhere between 25 and 35 units of insulin a day to manage their blood glucose. When we see people using 25, 35, 45, 50, 100 units of insulin a day, we can see how much more insulin resistant they are becoming because that's how much more insulin they are needing to keep their glucose under control. So the good news with her is that she used a CGM. So we talked to her about making some changes and addressing some of the symptoms that she was having. So what do we do next, right? When we're looking at this patient who's struggling with cravings, excessive eating, episodic excessive eating, just not generally feeling in control of her food, and her weight isn't going down despite dose escalation of her GLP-GIP. So our job at this point is to think about how do I reduce both endogenous and exogenous insulin? And what's going to do that? Reducing food intake, reducing calorie intake reduces the need for insulin. Reducing carbohydrate intake significantly reduces the need for insulin. Increasing protein and fiber, which allows for delayed gastric emptying and slows down how quickly our blood sugar goes up, will also reduce the need for insulin. Reducing body weight will ultimately reduce the need for insulin. Increasing exercise, especially postprandial exercise, which improves non-insulin dependent glucose uptake, which can be very helpful to manage blood sugar excursions. Improving sleep, reducing stress, and then ultimately reducing the use of her insulin. So what did we do? In her first visit, we talked about I wanted to find a way to lower the number of units of insulin she was using to manage her blood glucose. So we actually did something old school and we added acarbose. I added acarbose TID with meals and I asked her to cut her insulin down from 22 to 26 units down to 15 units. Because of her episodic overeating and her tendencies to have more craving than hunger, I started her on topiramate instead of her phentermine, which was discontinued at that time. During her initial video visit follow-up, she reported a couple of episodes of low blood sugar. At that point, we further reduced her prandial insulin. I left her basal insulin as is throughout for now. At her follow up visit, we added an SGLT2 inhibitor to further reduce her need for prandial insulin. So she wasn't at that point having any side effects to the medications. On this slide, you're going to see her weight graph. Okay, I don't know why my thing keeps, oops, sorry. But my arrows are all in the wrong place. It keeps moving. Okay, so here was her weight. At visit 1, the first time she met us, her weight was 207 pounds. Just between visit 1 and visit 2, which was all we did was actually added topiramate and reduced her insulin use and added acarbose, she had already lost some weight. And then by her third visit, this was her weight, and her A1C had actually gone down from 7.3 to 5.7. So by her third visit, this woman was off of all of her prandial insulin. So she was now taking only 16 units of Lantus a day. She was on acarbose 50 milligrams twice a day, added SGLT2 inhibitor, and tirzepatide 10 milligrams without increasing her GLP-1, just by reducing insulin and changing her dietary habits and controlling her stress eating. She had continued to lose weight and improved her glycemic control. So what are the clinical, actually, you know what, before I move on, does anybody have any questions? Doesn't look like it, right? Okay. So I guess stop viewing obesity and diabetes as separate diseases, right? Think about it as a metabolic dysfunction that needs a unified approach, and optimize for weight, insulin sensitivity, metabolic health, and not just glucose alone. So really think about holistically, you know, how's my patient sleeping? How's the stress level? How's their nutrition habits? What's their physical activity? The same things that we really address in a comprehensive obesity treatment. Oh, so I do see a question. Okay, so the question is, why didn't I increase tirzepatide before adding topiramate? Because what I forgot to tell you in this case earlier is that when she was having those episodes of excessive overeating, she wasn't feeling good. She was feeling nauseous. So increasing her GLP-1, which would exacerbate her nausea, was not really what I wanted to do. I wanted to be able to have her control her nutrient intake before I increased her GLP-1, which maybe eventually we will, to completely take her off of acarbose. But for now, we haven't done that yet. Okay, so practical approach for clinicians: diagnose insulin resistance early. When we see patients with pre-diabetes, intervene early, focus on all of those parameters for reducing insulin, you know, getting sleep in order, having a discussion about stress, having a discussion about carbohydrate intake, increasing protein intake, etc., and physical activity, of course. Treat obesity and diabetes together, and consider some of these newer agents. They're getting cheaper and cheaper, and the older agents like Trulicity, etc., are much more easily accessible. Focus on outcomes that matter: weight, blood pressure, lipids, energy levels, eating habits control, appetite control. Those are the things that we can keep asking patients to see what's helping them. We kind of went over this already. And that's about it. Those are my references. So quick and easy. Yeah, that's a good question. So I could have gone either way, but in clinical practice, I don't see as quick of a reduction in the need for prandial insulin as I do with acarbose. It just works very quickly because it's not going to allow you to absorb the glucose. So I just find it as a fast way to get people off of prandial insulin. Eventually, I take them off of it when I add on the other agents, and A1C has gotten controlled. You're welcome. Thank you for attending. So usually I check a fasting insulin or a C-peptide level. In the clinical trials that were done at large scale levels to look for insulin resistance, they find that if anybody has a fasting insulin level over 10, that technically is elevated, and if somebody has a C-peptide over 2, that is considered elevated. However, a HOMA IR is probably a more is a better way to do it, and HOMA IR is a test that you can actually just go into like one of those RPH calculators and you can just put in somebody's fasting glucose, um, and it'll give you a calculation for that. Um, yes, I definitely would. I mean, as this was like the first 3 months in our clinic. So as time goes on, I would probably actually I'd take it back for her. She had actually tried and failed metformin twice. Um, So OGTTs are great, especially OGTTs with insulin, but it's so cumbersome to do. I find the fasting insulin a super easy test that I can get going. If I really suspect that this patient's pretty insulin resistant, but all their testing is coming back normal, then I will do an OGTT. But most of the time, um, it's 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 pretty high. There was a question in there that I missed.
The checking fasting insulin, have heard recommended to check insulin after a meal to show resistance. I think is the one that we'll skip.
Oh, checking it after a meal.
You see that? Yeah.
Yeah, that is actually a more sensitive way to check for insulin resistance than a fasting insulin. But our lab, we are at the university lab, so like in order for us to do that, that would have been an extra ask. So I don't really do it. But yes, if we could do a postprandial insulin, that's going to get abnormal before just a random insulin sometimes. I find it fascinating. There was a study done by Dr. Jerry Shulman some many years ago at Yale, where he took Yale undergrad students who really had two criteria: one, that they had family history of diabetes, and two, that they were not athletes, like they were sedentary. And he showed that insulin resistant phenomenon of muscle uptake of glucose was already affected in completely healthy 20-year-olds. That if we can intervene then and say, hey, you know what, you should probably be one of those people that walks every day and really watches your carbs, then maybe we can really change the progression of disease. That if the pathophysiology of insulin resistance occurs in young 20-year-olds, then there's really a chance to make a long-term difference. Honestly, I'm just using rapid weight gain or obesity or impaired fasting glucose if they have it. Most of the time, just getting a fasting insulin test, I haven't seen any issues with getting coverage. The OGTT gets actually a little bit harder. Even if I put metabolic syndrome, checking a fasting insulin gets covered. But if somebody has metabolic syndrome, then by definition, they have insulin resistance, right? Because the low HDL and high triglyceride is a clear, and the waist circumference. I mean, those are all conditions of that. That's a really good question. I don't really know what the cutoffs are for that. I'm generally looking in a normal renal function patient, a C-peptide over 2, 2.5. It's a bit sensitive, but most of our patients will end up being over 3. So then I'm calling it. Sometimes it's just a way to get a conversation started with a patient to dive into, there's a lot of stigma and bias associated with this disease where people are thinking that they're just behaving badly and have no willpower and have no control over their habits. So if you can have biomarkers that they can look at and say, hey, you know what, there's something metabolically going on here. It may be driving your appetite. what are the things that we can talk about that can help us manage some of these things? And even as a conversation starter, sometimes I find that it can be very helpful.
Thank you, Dr. Patel. I keep like holding to see, is there going to be one more question?
Yeah, I know, right?
Feel free, anybody, to add more questions in the chat, and we can try to get those addressed too if we've got some more time. We're going to switch to another case presentation. We've got Dr. Leash. Where did she go?
Hi, I'm here.
Great. We'll just get the presentation back here in a second, and then we'll move that over. Excellent. Yeah, like we said earlier, it'd be super helpful if you want to put your camera on to help with the discussion. And then just whenever you're ready, Dr. Leach. Are you able to advance the slides? Or do we need Rita to assist?
Can you please advance?
Of course, just let me know when you're ready.
Yeah. Okay, so this is a different case. I think so I was volunteering to present this, but this looks like a different case, but I'll go through it. I think I was presenting about the genetic obesity, but I'll try to take this on, and Dr. Patel can help me here. So this is a 69-year-old male with class 3 obesity, with the initial BMI of 39, established care with the Metabolic Center on August 2025, last seen October 22nd. So past medical history, patient has diabetes with retinopathy and suspected glaucoma, and also has atherosclerosis of left lower extremity with diabetic ulcer. He has liver cirrhosis, he has hypertension, and he has high cholesterol. He is allergic to Ozempic. It causes GI upset. And also he's allergic to oxycodone. Current medications, Mounjaro at 7.5, metformin at 1 milligram extended release, lisinopril 5 milligram, atorvastatin at 40 milligram, and Cymbalta at 60, and Zetia at 10 milligram. Next slide, please. So initial visit in medical weight loss center. Patient came to see us for weight loss for liver preservation. In 2013, he was struck by a truck, status post left leg fracture, status post multiple surgeries. And then in 2021, he was diagnosed with an ulcer of left great toe, resulting in osteomyelitis and multiple debridement procedures. Diabetes mellitus is managed by diabetic center. Medication, Lantus 14 units, Lispro, PRN, and Mounjaro and metformin. Continuing, patient came to see for, okay. I think it's, next slide, please. So activity, limited walking due to left foot ulcer, strength training with weights for the upper extremity, kettlebell, abdominal exercises, Nutrition-wise, 24-hour recall, breakfast, yogurt with chia seeds, pumpkin seeds, lunch, sardine, protein shakes, dinner, fish or meat with greens. Other lifestyle thing, sleeps 3 to 4 hours per night, denies history of eating disorder, pancreatitis, glaucoma, kidney stones, seizures, substance abuse, and or family history of men too. Can you advance to next slide, please? Initial visit, height of 6 to 258 pounds, BP normal, heart rate normal, BMI of 33, max weight 308 pound in the past, 39 BMI. On exam, normal findings, no acute distress, appears well, central adiposity, neuro awake, alert oriented, and there's a boot on the left lower extremity, which is bandaged with wound dressing. Next slide, please. Lab results, glucose of 174, A1C 6.7, creatinine 0.96, GFR 86, ALT, ALP, AST within normal limits, bilirubin normal, platelets within normal limits. Notes from ophthalmology, nuclear cataract on both eyes, suspected glaucoma, bilateral, severe non-proliferative diabetic retinopathy of left eye with macular edema associated with type 2 diabetes. Next slide, please. So say ABIs back in January 2024 shows moderate arterial insufficiency on both sides. MRI of the liver, show liver elastography, liver stiffness consistent with cirrhosis. Liver fat fraction less than 5%, liver iron concentration less than 1.8, tri-liver within normal limits. Next slide, please. So discussion would be, what would be your plan if this was your patient? Any concerns about liver cirrhosis and GLP use? Any concerns about adding Jardiance in a patient with PVD and foot ulcers? Next slide, please. So visit plan was continue with the metformin, increase Manjaro, continue with the Lantus, Lispro, continue strength training, but increase protein intake to minimum 60 grams. Next slide, please. So the SGLT2 inhibitors in diabetes, so this study is showing there's a higher risk of amputation of toes, feet or legs with SGLT2 inhibitors. 71% of the affected participants having their highest amputation at the level of the toe. So more studies are needed to support their use. Currently results are inconclusive. Next slide, please. GLP-1 in diabetes with cirrhosis. So glucagon, so far, can you advance to next slide, please? So far, the studies have shown GLP-1s are found to be safer in liver and renal insufficiency. So as we found out from the other study, SGLT2, we are still investigating. So that probably will not be a good choice here, but Dr. Patel can add in if she has a different thing to say.
Yeah, I mean, they're not contraindicated per se in but there is a higher risk. If we're trying to treat obesity, there's still a lot of room to go up on Manjaro. I would literally try going up that path first, just and slow down the weight loss. Like there are cases of exacerbation of decompensation of liver cirrhosis with rapid weight loss. There's been case reports, but for the most part, we use it very safely. We have a lot of patients who are on the transplant list who need weight loss. So using it and just slowing down the weight loss by reducing how quickly you titrate the medication can prevent some of that from happening. I would actually, in one of the slides where it talked about increasing to 60 grams of protein, I would actually push that up even more. For a guy who's 6 feet 2 inches tall, 1 gram per kg, even with renal disease, if he had it, would be totally fine. And with liver disease, you're much more catabolic. I would try to push that up to over 90 to 100 grams of protein a day because it improves satiation, improves glycemic control. There's plenty of other studies that show that there isn't any harm in doing that. But I would save the SGLT2 for later if needed for further glycemic control is what I would do. I don't know if that's the right answer, but like that's how I would feel about this.
We'll find out as I'm finding out. So I think so far the discussion is going towards, okay, so as GLP-1s are probably safer, so we want to optimize them. And then increasing this guy's protein, he doesn't have a renal dysfunction, so he's lucky there. Glucose control is good for so far, but needs better weight control. And of course, I agree with Dr. Patel about increasing protein to match up with the 1 gram per kilo. So let's move on. So in subsequent visit, they found the Lantus, I think it was previously more, now Lantus, it's 8 unit, once no longer on Lispro. No hypoglycemic events so far. He's doing strength training. He does feel fatigued, but he has decrease in appetite. But I think some of it is also coming from the GLP-1s. He's eating protein, vitals, BMI is lower, 32. Exam findings are unchanged. Next slide, please. So yeah, exactly, that was Dr. Patel was also enforcing. So Manjaro was increased to 12.5. We continued with the CGM monitoring for this patient. Increased frequency of meals to meet that protein goal. And then that probably will help with the fatigue as well. And then you want to make sure their other vitamins are, corrected, especially with the GLP-1. You want to make sure they are not deficient in vitamin D, there are other B complex, iron. So you want to make sure if there's a room to optimize those vitamins. Next slide, please. So looks like patient continues to keep doing well. Manjaro was increased further, no side effects, no longer on insulin, feels stronger, increasing exercise, foot is healing, consumes more protein, is liking it so far, feels much better. Had some dizziness, and I think MRI was ordered to investigate it further, but BMI is 29, weight is holding up, blood pressure is holding up, and the ulcer is getting better. Next slide, please. Visit plan. So the plan was to continue with the Manjaro plus metformin. And then Lantus was discontinued, didn't need it anymore. Total body weight loss was 25% since starting this weight loss medication. Because of the dizziness, they ordered blood pressure, like ambulatory blood pressure monitoring. He was having low blood pressure because of the significant weight loss. Next slide, please. So this, I think we're discussing insulin versus incretin therapy in diabetes. So as we know from our previous talk, insulin is known to be obesogenic. So if we can keep patients' insulin levels low, as we just heard from Dr. Patel, by reducing carbs, increasing protein, switching them to GLP-1s and adding other things like metformin, SGLT2, acarbose, we just heard about that, and treating them with other obesity medications which are available. Topiramate was one. As like we want to decrease their insulin need as much as possible. Of course, if they, we are not talking about type 1 diabetics here, so that's a different discussion. But as much as we can lower, and as much as we can lower their insulin need, so much we are helping them with their weight loss. So 15 to 20% weight loss, studies have shown reduces cardiovascular risk in patients with diabetes, good diabetes control, and patient is meeting his goal. So we are lucky to be in this era of GLP-1s and GIPs and SGTL2. So I think we have a bright future for our patients with obesity, of course, diabetes, and this is going to keep getting better and better. Next slide, please. Recap. So incretin therapy, I'll read it. Incretin therapy is likely to be safe in patients with compensated cirrhosis. Some studies found a positive association, while others found no significant benefit. Avoid use of empagliflozin in patients with diabetes type 2 with peripheral vascular disease, as studies have shown increased risk in amputation with canagliflozin. More studies are needed to support safe use of empagliflozin. And when possible, stop or replace obesogenic medication like insulin, sulfonylureas, tizanidines, stuff like that, to decrease their need of insulin. Next slide, please. There you go. Thank you.
Thank you so much for helping present that. Do we have any other questions on that or any other comments on either that case or the presentation? Well, we have Dr. Vij and Dr. Patel here.
No, that was really a good case. It shows the complexity of the patients that we take care of in so many ways, like these are before, like if you had seen this patient even 15 years ago, we would have not even thought about having this big of an impact on his metabolic health. The fact that we can do these things now and really almost reverse the clock for a lot of these patients is really a gift. It's really a gift. It's kind of amazing to see these transformations. I mean, I think one of our most common referrals are actually from cardiology, right? Like they're like, just go down the hall and go see the metabolic health clinic because your metabolic syndrome is out of control. So, but we didn't really have options like this before. So I think it's incredible. I think Dr. Vij said it right, that we're at the cusp of a revolution of how we practice medicine. And I think the more we get comfortable understanding the lived experience of our patients, the better clinicians we're going to be.
The question says, please elaborate on rapid weight loss and liver dysfunction, if either of you can address that.
You want to take that? You want to take that?
I will have you take, Dr. Patel. I'll have you take that.
Well, I mean, okay, so I was doing a deep dive on this because I do have a cirrhotic patient that we were trying to figure out, like, what should we use? I mean, she's very complicated. She also has this like really old, strange manganese toxicity problem. So like she's got like 90 things she can't eat because they're high in manganese. So it's a little confusing. But anyway, so her issue, we were looking at what Wegovy does. At the end of the day, Wegovy is approved for liver fibrosis, but there's no contraindication to liver cirrhosis, but there are multiple case reports that show that if weight loss is very rapid, there is worsened decompensation of liver. So we define rapid weight loss at more than 3 pounds a week. So we're trying to adjust it to like up titrating slower to keep people at a pound a week to 2 pounds a week. So don't go too low on the caloric intake. Try to manipulate that with making sure that they're eating enough meals during the day, and like avoid more than 3 pounds a week of weight loss. Any experience you have, Dr. Vij, with some of these things?
So yeah, definitely. I think I agree with you. Rapid weight loss, you want to avoid. And then again, another thing is like we have to be very careful. Not in this context, different like diabetic retinopathy. Also, you want to be very careful. That's another way where you have to be careful with GLP-1s. Yeah, but I agree with you. You want to avoid rapid weight loss with cirrhosis people having
Yeah,
liver.
and we see these patients more frequently. Like sometimes our diabetics will go every 3 months, but some of our liver cirrhosis patients, we try to see them every 6 weeks, at least between me, the dietitian, and my APP. So we do try to do that a little bit more often. But sometimes with these GLP-1s, it's hard to control the weight loss. Some people just take off. They're hyper responders, and it's hard. So you have to kind of balance that a little bit.
There's a comment in here, just 2 comments, not questions. She says, appreciate the idea of using acarbose, if I said that right, in case 1. And I'm impressed by case 2's speed of recovery. These meds give back hope to patients and providers. Thank you for your comments.
Definitely. I think Dr. Patel brought that acarbose. It's highly underutilized drug. I think it can be very helpful.
Yeah, for prandial insulin, it's like
Yeah.
magically good for so many patients, right? I mean, if our primary goal is to lower their bolus insulin, it works really well. I mean, yeah, you get some GI upset here and there. I use it a lot for my post-bariatric surgery patients, which is why it's always kind of top of mind. But yeah, I find that one, and then pramlintide, Prandin can sometimes be a good one too, like some of these old stuff. And let's not be afraid of things like TZDs either, because while TZDs do increase a little bit of weight, they actually redistribute weight to improve insulin sensitivity. So sometimes it can actually be a tool in getting people off of insulin. When you put them on something like Actos and they're redistributing where their body fat is, it can actually be helpful in the long run. So there's pros and cons, right? If you're using something like that, like TZDs are a true insulin sensitizer. Problem is that they cause you water retention and weight gain. But if you're combining that with the GLP-1, you're not going to have that issue, and you're going to remove a lot of liver fat. So sometimes go back to our old drugs and combine them with GLP-1s. It's actually
And if I'm not mistaken, acarbose it sometimes help them with the dyslipidemia as well.
Yeah.
Yeah.
Yeah, I think so. I mean, I think it's the metabolic syndrome improvement that really helps, right? If you're taking fat away from the ectopic areas, even if you have to put it subcutaneously, you're putting it in a space now that's not causing metabolic damage. Oh, so how do you approach GLP-1 use in patients with diabetic retinopathy? So we actually work in conjunction with our ophthalmologists, and most of them are of the opinion that if you don't rapidly correct glucose in the long run, you're actually going to improve their retinopathy risk. So we usually just try to not up titrate. Like, I don't remember the last time I up titrated GLP-1s like they were meant to be titrated. I think Dr. Vij would probably tell you the same thing. Like most of us in clinical practice actually titrate to weight and A1C. We don't really titrate to the schedule. So I think that can be another way to just manage the issues that happen downstream.
Yeah. And another thing for diabetic retinopathy, if you were just planning to start somebody on GLP-1, what you can do, you can have a baseline retinal exam. So if they don't have retinopathy, of course, there's no problem. But if they have baseline retinopathy, you want to counsel patients. So they need to know what are the risks. Of course, and I agree with Dr. Patel, titrating them very slowly, not avoiding that rapid weight loss, rapid glucose control. I think that's the key to go. You can still do it, but you have to be just make sure you counsel your patient. If they notice any new changes, they have to report right away.
I was just reading the comments. Any other questions? This has been a really good discussion. This question is, what about pre-diabetic patients that wear a CGM for data? Do you ever diagnose from those levels or just A1C?
Yeah, I mean, I think we should be diagnosing diabetes way earlier than an A1C of 6.5, but insurance companies don't agree with me. So most of the time we have to, unfortunately, for diagnosis, follow the standard criteria of fasting glucose over 126, random glucose over 200, or A1C over 6.5. And I don't know, Dr. Vij, if you know, but I've never really been able to use CGM data to submit for that.
No, I have not. But recently, what I have tried, because a lot of my patients, by the time they come see me, they're already 6.4 or so. And then I put them on Ozempic and the things go down. And then what I have started using now is just their fasting sugar, because if I look at their data, at some point they're hitting that 126. So I use that. No, I haven't used the CGM data, but just trying to make sure I get anything I can do to get these.
I agree. We do that too in our clinic. We're always like scrounging, Oh, she had a random glucose of 200 3 years ago. You have diabetes.
Yeah, there you go. Yeah. Just to satisfy these insurance companies.
Yep. As these indications get more and more down the road, like as we start getting more of these MASH indications and all these other indications for the use of GLP-1s, I think it's going to get in some ways more complicated and in some ways a little bit easier too. So we'll see how things go.
Make sure everybody had the opportunity to ask a question or make a comment. And I think this has been a great discussion. Thanks, both of you, to presenting and offering your expertise. Really appreciate it. Thank you, everybody, for attending today. We will have the recording of this posted and distributed through the Echo platform later today. Yeah, thanks, everybody. Oh, yes, and credit for attending. If you don't have an account yet with the Academy, make sure you send us an email through that. And then there's links that Katie has posted there in the chat, if you can provide any feedback to the session. So thanks, everybody. Appreciate you being here.
Thank you, Dr. Thank you, everyone.
Thank you, Dr. Vish. Thanks for setting everything up, guys.
Thank you.
Thank you.
Yeah.